This presentation is about the palliative care phase, and my name is Sabina Clapham. So why were phases developed? They were developed because palliative care focuses on the goals and priorities of patients and their families rather than the disease itself. Palliative care needs are identified and addressed through care planning activities, and palliative care phase helps to define the care plan and provides a framework to respond to identified needs. The phases are used to focus on care planning, to prioritise patients for admission and discharge, and importantly, enables a communication system between teams and within teams. The phases are stable, unstable, deteriorating, and terminal. So how does a stable phase start? Well, the patient's problems and symptoms are adequately controlled by an established plan of care. So essentially what you're doing for this patient is working, and you have further interventions to maintain symptom control and quality of life. So this could be anticipatory medications, for example. And the family carer situation is relatively stable and no new issues are apparent. This phase will end when the needs of the patient and or family increase, requiring changes to the existing plan of care. And you should see this in your PCOC assessment scores. Patients in the stable phase will typically have 0 absent to mild symptoms and problems. The actions for the stable phase, well, you continue your care plan because what you're doing is working. And if it's appropriate, you consider discharge. The unstable phase. This starts when there's an urgent change in the plan of care required or emergency treatment. And it could be one of these three things. The patient experiences a new problem that wasn't anticipated. The patient experiences a rapid increase in the severity of a current problem, or family care circumstances suddenly change, impacting on care. In this phase, you should see at least one symptom or problem in the severe range. The unstable phase will end once you put in place a new care plan and you've reviewed it. And you're not going to change it any further because you can see there's evidence that it's working. For example, you would see a reduction in your PCOC scores, symptoms and problems, and you wouldn't see any other increase into the severe range. However, it doesn't mean that the symptom or crisis has been fully resolved, but there's a clear diagnosis and a plan of care. In this situation, the patient enters the palliative care stable phase or deteriorating phase. It can also end because death is likely within days. So no matter what the severity of symptoms and problems are, if a patient is dying, they're in the terminal phase and you're providing terminal care. Actions for the unstable phase, well, you need to urgently intervene and escalate to the right person within your team to provide care. You need to change the care plan, and there is urgent medical, nursing or allied health services required, and you need to review this patient within 24 hours. The deteriorating phase starts when the palliative care plan is addressing anticipated needs, but you actually have to review it again because of one of these things, one or all of these things. So the patient's overall functional status is declining, and you would see this change in your functional assessment tools. The patient experiences gradual worsening of an existing problem. The patient experiences a new but anticipated problem, or the family carer experience a gradual worsening and distress that impacts on care. So for example, you might see scores in the moderate range of symptoms and problems and a change in the functional assessment. It ends if the patient's condition plateaus. So again, you can see this in your assessment scores. There's been no change. And this means that the patient's phase is now stable. Or it could end because there's an urgent change required or emergency treatment or family care experience suddenly change. And in this case, the phase is unstable for this patient. Or the patient is showing signs and symptoms that death is likely within days, in which case the phase is terminal in providing terminal care. So actions that you need to change the plan of care are required to address needs, but it's not urgent. It just needs to be done as soon as possible. Referrals may be required and extra family and carer support may be needed. Terminal phase is that death is likely within days and it ends when the patient dies. However, if the patient's condition changes and death is no longer likely within days, the patient can move to the stable or deteriorating phase of care. So actions: well, you commence terminal phase care, you communicate changes to family members, and if the patient's not likely to die within days, you can reassess phase. If the patient dies, you end the episode and there's no further PCOC scores. So how to integrate phase into everyday practice? Well, include it in clinical handover and team meetings and use it to prioritise care, determine the frequency of medical or clinical contact, to trigger referrals or trigger after-hours services. Key messages: the palliative care phases, they're not sequential, so a patient can move back and forth in as many phases as is actually occurring for them. But if you're not sure, just talk to a colleague or bring it up to your multidisciplinary team. An outcome in PCOC is measured by the change from the beginning to end of each phase. So that's important to know. And also that PCOC assessments are used together to help inform the palliative care phase. Here you can see on our website a lanyard card that is an abbreviation of PCOC's assessment and response protocol. Thank you very much.